Good morning. I think I'm talking mostly to the online audience, but thank you for joining as well. My English is very fast, so Volkan, if I'm speaking too fast, tell me to slow down, yeah? But anyway, thank you for joining today. There's one simple thing that I want to discuss, and that's change. And what about change? We know that change is the only constant in our life. We know that everything will need to change, including healthcare. Let me give you an example. Why do we need to change, and why do we need to change now, is the question. So if you look at even myself throughout my lifetime, this is a picture of me from 1998. I was 18 years old. Obviously, I had less facial hair, a bit thinner than previous. Then if you look at me in 2014, I was 140 kilo. What caused me to change between 1998 and 2014? A few years after 1998, I had just been married, had some kids, got my new job, and I wasn't very focused on my well-being. Well, in 2014, I decided to change again. And I started competing in different types of events around the Middle East, doing things like the adventure run and different things. But the point here that we're trying to make is that it's all about change, and all about constant change. So when we talk about healthcare specifically, what do we know? We know that CEOs are tasked to provide performance over time. This is what healthcare systems are supposed to do, provide performance over time. So when we asked CEOs, what are the things that they would want to focus on? What are the challenges that they see in being able to provide that performance? They came up with 3 different things. The first one was talking about reducing clinical variance. Clinical variance meaning that we should be getting the same standard level of care regardless of what type of physician we see or which physician we see in a specific specialization. Right? We know that with clinical variance, this has a lot of downstream effects in terms of being able to provide standardized care, overall revenue, overall costs to a hospital as well. The second thing that the CEOs were concerned about was utilization, and making sure that we are, as a hospital, are not misusing or misutilizing the resources that we have within our organization. And when we talk about misutilization, we're talking about resources, we're talking about order profiles, we're talking about physical resources as well as personnel resources as well. And then lastly, the third challenge, or the third initiative that CEOs would want was to have financial innovation. What are other ways they can do to have cost-cutting measures in their hospital organization and in their healthcare systems? Well, the question is, how do we do that? Or how do healthcare systems do that? So what they did is they started looking at what is their biggest cost to a healthcare organization. The biggest cost to a healthcare organization is a physician. 80% of a cost to a health system is based off of a decision that's made by a physician. 80% of the costs to a healthcare system is determined by a decision that's made by the physician. So let's dig into that a little bit deeper. When we started looking at what are the practices that clinicians have and that physicians have, we started looking at how and what type of practices that they do in their day-to-day. We noticed that about 15% of physicians were unsure about what tests to order when they have a patient in front of them. That means that 1 out of every 7 to 8 times, a physician is unsure about what type of test to order. We also know that 30% of the orders that were placed are clinically unnecessary, clinically irrelevant. So 1 out of every 3 tests that are placed have no bearing on the outcome of that patient. And lastly, we know that 40% of the orders that are needed are never placed. 40%. Which means that 2 out of 5 tests are never even placed on a patient. What does that mean? That basically means at the end of the day, the physician does not have the right data or enough data to make sure that they are making the best decision for their patient. That's just on the ordering side. When we start talking about how to interpret results, physicians have self-reported, 8% of physicians have self-reported that they are unsure about how to interpret lab results. And this is self-reported. So this is physicians saying this about themselves, which means that 8% is probably very low. Probably very low. It's probably a much higher number than that. You know, I have a sister in the United States, and I asked her, you know, when you get lab results, how do you know what to do with it? She says, I do one of three things. I either know from my education or my experience. I can call the lab, or I can call the radiology or pharmacy and talk to, you know, the ancillary departments to get more information, or I can Google it. And we know that Dr. Google is the most, the strongest doctor, most powerful doctor in the world today. Yeah? But the question is how do we start proactively managing against that? How do we proactively manage against getting the right information to the physician at the right time? Well, we know that if the physicians don't have all the data in front of them, then we know that there is never going to be a standard level of care. Right? We want to have the most optimal outcome for the patient. But if we don't know what the standard is, then it's very difficult for us to be uniform throughout. To give you an example, we know that a patient that comes in has a high HbA1c, most likely diagnosed with diabetes. Now, what's the best way, or what's the best patient pathway you can put, or what's the best protocol you can put that patient on? Well, if you go to the web and you put in best protocol for diabetes, you'll find 52 different pathways for diabetes. It essentially says that there's no best way to do it. There's only a best way to do it for that patient profile, because every patient is going to have a different pathway. So we know that there's going to be 3 logical outcomes when a patient comes to see a physician. The first way is that the patient comes and they are immediately diagnosed. It's done in a timely manner, and the cost is very low. This is the optimal outcome. This is what we want every patient to go through. Yeah? They come in, they get diagnosed, they get put on a protocol, they recover, and it costs very little time to the hospital, and it costs very little money to the healthcare organization and to the patient. The second outcome is that patients come in, they get put through a few therapies, some work, some don't work. Eventually the patient gets better, but this takes a little bit more time and takes more cost. And unfortunately, most of the patients go down this pathway, which is to go down a few different therapies before they actually get diagnosed and recover, and it costs a little bit more money and a little bit more time. Worst case scenario is that a patient never receives the proper protocol that they should, never receives a proper diagnosis. This takes a lot more time, a lot more money, and unfortunately the patient has to continually run through the healthcare system multiple times. Now, all the data that we have up here is showing us that a single physician potentially does not have the data they need to make the decision at the right time. This is for one physician. Think if you multiply this by the hundreds in the healthcare system, what the downstream effect of this would have. So the question is how are CEOs solving this problem today? Most CEOs have started investing in an EMR, or an HIS system, electronic medical record. And theoretically, in an EMR, what you're doing is all you're doing is aggregating data into a single source. So you're putting data from different places into a single source. It's a repository of data. And you put in some rules in there that fire based off of some of the guidelines that are put in. And usually they come through what? They come through pop-ups that a physician sees. And as a physician sees a pop-up, they usually click close on it, right? Now, the average number of pop-ups that come for every patient scenario, for every patient that's in front of their physician, is about 6 to 7. So that means that for every patient, a physician is seeing 6 to 7 pop-ups or alerts on that patient. How many pop-ups are they going to see? They go through alert fatigue. So all they do is they close, 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 right? It's not being effective. They're not actually able to see what's actually important information to make sure that they're caring for their patient. The other downfall when it comes to EMR systems is that EMR systems are designed for clinicians, for physicians, especially the physician module, without taking much into consideration from the ancillary departments. So essentially what this does is this locks the expertise when it comes to the different type of ancillaries that we need to put into there: laboratories, radiologies, pharmacies, HIM. So these expertise that are never put in or never endorsed for the clinician doesn't have the full value of knowing what happens in an integrated care cycle. So how do we solve this problem? It's very simple. What we need to do is we need to go beyond and extrapolate a bit more on the 5 rights. What's the 5 rights? The first one is information. And information means the data that we put into the system, but not simply data points. It is what are the insights that we can gather based off the data that's in the system? What are the analytics that we can put into there? The next 2 is talking about format and person. When we talk about format, we know that every patient is not the same. We know that every physician is not the same. So we need to make sure that the information that we have is applicable to that patient and is put into a format that makes it easiest for that physician to be able to do something with it. And the last 2 pillars of the 5 rights are the time and channel, making sure that we are getting the data to the clinician at the right time using the right channel. So what we do at Abbott is we create a clinical decision support system. And in clinical decision support, we essentially unlock the expertise of the ancillary departments and get them to be more involved in the overall integrated clinical care cycle. So we take patient data, and we use patient data such as patient history, family history, physician notes, clinical notes, historical results, and we put it into algorithms using physicians' input, using pathologist input, radiologist input, pharmacy input. We take in different types of lab results, ancillary type of results. We identify internationally recognized protocols. And we take that international protocols, we look at the national level, we look at the local level, and we localize those algorithms to be applicable to the patient population. And what we're able to do with that, just by unlocking this expertise, is we're able to create a custom format. And we make sure that that custom format puts it in a way where we can get the right information in the right format to the right person at the right time using the right channel. So we're able to do that with using the 5 rights. And hopefully, the goal is to make sure that we move patients more towards the most optimal method of care, which is option A up there, which is providing care in a timely fashion, the most cost-effective, and making sure that the patient is getting the right diagnosis the first time. What this allows us to do then is when we're able to start standardizing that, we look at the overall clinical variance, the utilization, and the financial innovation, and we're able to provide more value not only from a revenue stream, but an overall cost-cutting measure. So essentially what we want to do is we want to take data that we have in our system, create insights across that, and be able to produce some sort of action as well, so that we're able to take the lab information and the lab data and create the insights that a physician would have at the right time using the right channel and across all the 5 rights altogether. I think I have to be closer for this to work. Yeah. So when we talk about specifically ancillary departments and we talk about diagnostic testing, most of the errors that actually occur in diagnostic testing are at 2 places. At the time of order, meaning making sure that we have the right selection of orders, and at the time of result, making sure that the interpretation is correct and the clinicians are able to interpret correctly based off that patient profile. So when we look at impact of satisfaction and we talk to healthcare executives and to lab directors, you'll notice that around 60 to 70% of healthcare executives believe that the lab has an impact on patient satisfaction, clinician satisfaction, and employee satisfaction. What does that mean? That means that we're able to provide a method and a mechanism to make sure that we're not only doing what's right for the patient, which is the most important, but we're also making sure that satisfaction is there from a provider perspective as well as an employee perspective. So essentially what we want to do is we want to change the mind shift. We want to change the mind shift of the ancillary departments from being a manufacturing site, not somewhere where you just send a patient to get an x-ray or send a patient to get meds, pharmaceuticals, send a specimen to get a result, but we want the ancillary departments to be completely involved in the entire decision engine of integrated clinical care. It's an overall mind shift change. So how does Abbott support that transformation? It's very simple. What we do with clinical decision support is we take unstructured data from different areas of a diagnosis cycle, nursing notes, physician notes, previous family history, previous results, and we put it into a structured format and make sure that we deliver it to the clinician at the time that they need it the most, at the patient's bedside. And how do we do that? It's very simple. We take a system, implement it into a hospital. We take the expertise of the clinicians of that hospital or healthcare system. And when we talk about expertise, we're not talking only physicians. We're talking about laboratory, radiology, pharmacy. And we integrate that all into an algorithm that we build out that is based off of your patient population. So we take an international guideline such as diabetes, and we work with your local clinicians and local experts to create an algorithm based off of the international guideline, but applicable to your local patient population, and we implement it into your system. Then with that, we're able to produce actionable outcomes and insights based off of your experts and determined by your healthcare system for your patient population. So as an example, as you can see up here, we take international guidelines, national guidelines, local guidelines. We talk about the clinical best practices for your health organization, and we create a rules and clinical decision support algorithms. So some of the ones that we've already done with international guidelines is diabetes, lipid profile, ILD, anemia, hematology, chronic kidney disease, HIV. And what we do is we don't only look at it from a clinical perspective, right? We try to figure out how can we improve processes overall, yeah? How can we improve turnaround times, workflow, automation, develop more insights? But at the same time, from a clinical perspective, how can we help with overall screening, identifying the right stage of a disease state, being able to do follow-ups, being able to identify comorbidities in advance. And then we look at the overall outcomes of a patient. Now here's a quote that just because I have an app on my phone, a fitness app on my phone, doesn't mean I'm an athlete. Yeah, just because I have a fitness app on my phone doesn't mean I'm an athlete. Very simple when it comes to healthcare systems as well. Just because you have a healthcare system doesn't make you a clinician. Just because you have a healthcare system app doesn't make you actually use that app, right? So what we have to do is make sure that we're not only putting data into a system, but we're creating insights based off the data that's going into it. We're using that data to our advantage, yeah? So what we want to talk about here is that when we talk about clinical decision support, it's not just notes. It's not just a number, right? The number is the lowest form of maturity that you can have in a healthcare system. Providing a lab result is the lowest level of healthcare that you can provide. What we want to do when we go up the value chain is we want to get an answer, develop insights, be able to do more predictive behavior, indicate therapies. Because at the end of the day, what do we want? We want precision medicine. That's our goal, is to get precision medicine and patient-based precision medicine. We want to get the same standard level of care. And not only using technology, because remember, just because I have an app on my phone doesn't make me an athlete. So it's not only using technology, it's being able to get the information to the right person, in the right format, through the right channel, at the right time. And that's what clinical decision support allows us to do. So if you look here, what we traditionally provide from a lab perspective is a numerical or quantitative result. Now, with something like clinical decision support systems, you're able to provide more patient-specific interpretations, right? We can say, for example, this patient has hyperlipidemia, no previously noted levels. Secondary causes could be excluded. If confirmed, these levels may justify lipid-lowering therapy. We can start providing guideline-based recommendation. The recommendation is the initiation of lipid-lowering therapy to prevent cardiac events. We can put in risk score calculations. We can even put insurance information. Because remember the three things we're looking at. We're looking at what? We're looking at clinical variance, we're looking at appropriateness of utilization, and we're looking at financial innovation. With something like clinical decision support, you're able to tackle all three of those things, right? We're able to look at insurance information, we're able to do guideline-based recommendations, we're able to identify the type of orders or follow-up orders that would need to be placed. So with what we want to do at the end of the day is, what is healthcare? Healthcare is personal. Yeah, healthcare, yes, it's a business. Yes, it's an organization. Yes, it's something that's a job creator. Yes, it's something that's government regulated. But at the end of the day, healthcare is personal. And the way for us to make it and keep it personal is by knowing why the patient has a specific issue, understand the patient's conditions, and be able to engage with that patient in a way that is most applicable to them, right? When we talk about clinical decision support, we're not talking about treating against a disease state. We're talking about treating a patient against the disease state. We have to make that distinction. Like I mentioned earlier, there are 52 different best practices when it comes to diabetes. 52. That just means that every patient could fall in any one of those categories. So we're not treating against diabetes, we're treating the patient against diabetes. So when we talk about the overall diagnosis cycle, the main areas of where a clinical decision support would help out was at the time of order. So as an example, like I mentioned in the first couple slides, that 30% of the tests that are placed are unnecessary by a clinician. And 40% of orders that should be placed are never placed on a patient. Well, what if there was a system that could proactively tell the clinician that, listen, these three orders that you just placed are clinically irrelevant, or there's a result that already exists for this. An HbA1c was already placed 2 weeks ago, and we know it's valid for 3 to 6 months. You don't need to place another HbA1c. Or what if proactively we can say, here's another 2 or 3 tests that you did not order that may have a bearing on the outcome of this patient. Now it's starting to suggest some of the guidelines that you can put in based off the protocols that we built out into the system. Yeah, we can start sending alerts, real-time alerts, if it's a critical type of result. We can start talking about follow-ups. We can start looking at differential diagnoses. You know, here's a potential diagnosis for the patient based off of the historical results, based off of the current results. We can talk about lack of compliance. So now you can start looking at which clinicians are complying with protocols and which clinicians are not complying with protocols. And again, this is not to monitor clinicians. The point is not to monitor physicians. At the end of the day, you cannot take the human element away from patient care. The physicians still need to be able to make the best decision for their patient. All we want to do is supplement that with making sure that they have the information at their fingertips to make that best decision. And at the end of the day, we can help out with follow-up appointments, making sure that patients are coming in and out in a regular way, but also making sure that they are at home care is being taken care of as well. So I'm going to go back to the question that I had in the beginning. Why change? Why now? If you remember, the first thing I said was what? The only thing that's constant is change. And I showed you a few pictures of myself when I was in 1998 versus 2014 versus today. It's a big difference. We know that changes are always going to happen. And we know, and I'm a family man, I have 4 kids, and if you see my 4 kids from 10 years ago versus today, they're constantly changing. Yesterday is different than today. So we know that change is happening. Change is going to happen whether we jump on board or not. What we want to do is making sure that we live with that change. We want to make sure that when the kids are young, that we know that when they get older, that the life will be a better place for them, that we're doing something that's advancing healthcare overall, right? We know that there's going to be change regardless. Whether we like it or not, there's going to be change. Change is the only thing that's constant. But progress is impossible without change. If we don't progress, if we don't change, we'll never be able to have progress in healthcare at all. And those who cannot change, And those who cannot change their mindsets cannot change anything. So the first step in us being able to change is changing our mindset. If you remember, I said earlier that we don't want to look at the ancillary departments as a manufacturing site, right? The ancillary departments, radiology, pharmacy, laboratories, should all be a part of the integrated clinical care system. 70% of the decisions that are made by a physician is based off of a diagnostic result. 80% of the costs that come to a healthcare organization is based off a decision that the clinician makes. So why are the ancillary departments not more involved in the overall integrated clinical care? Why do they not have more influence in what happens at the physician's tip of their pen? We need to get the ancillary departments more involved when it comes to clinical decision support. And I know I spoke a little quickly, but that's really the gist of the conversation, that I want to make sure that we focus on clinical decision support being a vehicle of change. I leave it for any questions, if there's any questions that anyone has. I think I did that very quickly, yeah? 30 minutes. Any questions? And I apologize if I speak too fast. My wife tells me I speak too fast. Sure. Yeah, so just for everyone who didn't hear, the question was, are there any issues when it comes to patient data, how it's stored and whatnot when implementing a system like this? So of course, there's national guidelines, or national laws that come into data privacy and those types of things, right? So of course, all the patient data that goes into any type of healthcare system is something that has to either be de-anonymized, or anonymized, I should say, or has to be something that sits within the physical location of the healthcare organization. So when we implement systems like this, we make sure that we implement it on site, and the only time any data is removed, if it's either anonymized and it's been approved by the local organization, right? So even when you implement systems like this, and this is for any HIS company, there will be no access to that system, no access to that patient data outside of the healthcare organization unless it's been approved and unless it's been anonymized. Yes? So there's two things that I want to mention about that. There's language in terms of building out the rules and algorithms, and then there's language in terms of output from the system. So the report, what the report looks like. So I'll talk about both of those. So when you're inputting rules into the system, so first of all, I want to make it clear that this is an IT system made for and made by clinicians, which means that you don't need to have an IT background to build out the algorithms. We've built it or it's been designed in such a way that you can put in simple English. So you can say, if fasting glucose is greater than 6.9, then patient has a history of diabetes, right? You type it in simple English, and the system itself translates that into syntax language. Now that part is dependent on English. The output can be put into any language. So the output, you would say, history of diabetes as an example, you could put that into Turkish, saying the history of diabetes, and that can be translated back or sent back to an HIS system in Turkish. Now what it can't support are special characters. So right now, the only characters that we support are the English letters, but majority of the other languages use mostly similar type of English letters, so we don't have special characters today. It's a good question. Any other questions? No questions? Okay. Thank you very much. Hello. Oh, thank you. Thank you, thank you. Thank you. Thank you very much. Thank you, thank you.